welcome you to the next edition of the APSC TCIP joint meeting on intravascular imaging. This time the topic is intravascular imaging in acute myocardial infarction. And first of all, I would like to thank the APSC and all the members of the TCIP group, the Transcontinental Coronary Imaging and Physiology group, to get this started. It is my pleasure to introduce the distinct moderators, co-chairs, Dr. Alan Chen. He is the director of cath lab of the Queen Elizabeth Hospital in Hong Kong, and Dr. Paul Ong, senior cardiologist in Mount Elizabeth Novena Specialist Center, Singapore. And we have very experienced specialists and experts from all around the world, starting with Australia, Dr. Sidney LO from the Liverpool Hospital in Sydney, Dr. Lucio T from Buenos Aires, both very experienced interventional cardiologists, CTO experts that made their name in the complex PCI area around the world, and Dr. William HAU from the Chinese University of Hong Kong, China. He is a senior interventional cardiologist with experience of over 20 years in intravascular imaging. Next, it will be Dr. Ho LAM. I think we are all very familiar with him, interventional cardiologist from Tuen Mun Hospital in Hong Kong. Very the driving force behind the TCIP and the TEX club. Then the next speaker will be Dr. Chee-Yang CHIN from the National Heart Center in Singapore, and Dr. Raymond CHEUNG from the Tuen Mun Hospital in Hong Kong, China. This time we got very experienced experts, panelists from around the world. Dr. Mirwad Alasnak from Saudi Arabia, Dr. Ka-Lung Chui from Hong Kong, Dr. Jiangming Pham from Singapore, and Dr. Zen Win Lee from Malaysia, Dr. Jonathan Sang from Hong Kong, and Dr. Vincenzo Vizzi from Italy. It is my big honor to host this session with all you guys and share the experience. So without further ado, let's get started with our first speaker, Dr. Sidney LO from Australia. Sidney, please.
Thank you very much. Can you stop screen sharing? I think I cannot start the screen share. Thank you. I'll go to my talk. Thank you very much. And it's great to be here with everybody again. And actually, my talk is not on intracoronary imaging. And of course, it's on physiology. And I'm very honored to be with the group. And let's move on. And so my conflicts. So we focus a lot on the epicardial coronary artery in STEMI. And this idea that time is muscle, the quicker we open the epicardial coronary artery stenosis from coronary plaque rupture, we may save muscle. The longer we wait, the longer we will have more damage. And the open artery hypothesis, which has dominated what we've done for primary PCI over the last few decades, have been actually tried and true, saved many lives, but we're trying to do even better than we have. And one of the things that we've seen, this is from Naveen Kapoor, who runs a door-to-unload trial using Impeller, is that despite what looks like a very successful anterior infarct LAD occlusion and primary PCI, despite echo showing a very good LVEF and what appears to be a very therapeutic result, patients feeling very well, on cardiac MRI, they actually show on cardiac MRI that a massive anterior infarct has actually occurred. And look, when the patient presented, he had LV dysfunction as well as a very high EDP. Now, we try and do better and preserve more muscle. Traditionally, when I was a student, The ECG was the key thing. If you have more than 70% ECG SE segment resolution, even at 50%, the probability of epicardial coronary artery opening by the time you did the angiogram would be high. And of course, complete resolution would imply that you actually have a reflow or actually microcircuitry reperfusion. But of course, even though you may do primary PCI, the ECG may still not be normal. And this relates to potentially the microcirculation still being infarcted. These are, of course, this connection of vessels. We focus on the large epicardial coronary arteries, and the microvessels, arterioles, probably around less than 100 micrometers is what we're talking about. It is a large part of the circulation we've ignored in the beginning of our work in primary PCI, but now increasingly recognized as being very important. There is a method now of assessing how the IMR actually is. We're using a pressure flow relationship, using pressure to describe coronary flow across the epicardial coronary vessel, but we're going to also look at what's happening in the microcirculation more easily. Angiographically, we've used things like TIMI flow grade, corrected TIMI frame count, a semi-quantitative approach, a myocardial perfusion grade, and a blush grade to see if there is good flow in the myocardium. This is classic Eugene Bornwald. I think he did it on the back of a napkin on a plane and said basically this TIMI 0, TIMI 1, TIMI 2, TIMI 3 with perfusion of the artery and normal flow, and a perfusion with no illustration of the complete artery. Well known to most people. You can count the frames, shooting a coronary angiogram at 30 frames a minute and picking anatomical landmarks such as the mustache in the LAD and counting the frames that hit that landmark to count what is thought to be normal frame count, and a way of assessing how much flow there is. And then we look at the blush grade, very, very semi-qualitative about the blush quality in the microcirculation beyond the epicardial coronary arteries. We know that, of course, if you had good perfusion grade, then you may have less likelihood of events such as death. Now, is there a role for FFR in a culprit vessel during STEMI? And it is not routinely done, largely because I guess if you're infarcting a large part of your perfusion territory, it may give you a false reading about what is actually ischemic. So essentially, not believable was negative, and really there's no role if you're just constituting LAD opening of the epicardial coronary artery. But of course, if it is positive for ischemia, maybe it's reflective of ischemia. So what about non-culprit vessels? And this relates to multi-vessel disease during STEMI, and there's been many studies. There's a small sub-study of the NAMI 3 pre-multi, and notice that numbers are fairly small. And if they use FFR to guide a non-culprit vessel for revascularization, there's a reduction in events such as all-cause mortality, reinfarction, and TLR. COMPLETE was a big trial looking at non-culprit revascularization. Notice the number needed to treat to reduce endpoints was only a small number, about 37. And you can see that the rule was in that non-culprit vessels, angiographically more than 70%, you can stent at a stage procedure. If it's between 50 and 70%, you need an FFR less than 0.8 to actually qualify for PCI. But only 5% of the population really needed FFR, and almost all of them were significantly ischemic. There's been another trial called Flower MI done in France, looking at a non-culprit lesion of 50% or more angiographically, and then using randomized to angiographically guided versus FFR guided PCI. Just a criticism of the study in the sense that in the FFR guided arm, you can see that just over half had ischemic lesions. And a lot of them were really just 50 to 69% lesions, maybe doesn't need to be stented. And overall, in this study, there's no much difference. In fact, a small signal perhaps to more events in the FFR guided arm. So there's not a lot of difference with using FFR. What about IFR? Well, for non-culprit lesions, it seems to agree fairly well. Of course, the longer you wait after the STEMI event, the more likely that they will agree, because 80% of the time in stable patients, they are concurrent. Let's talk about microcirculatory salvage in STEMI. In Australia, we have about 15,000 STEMIs on an annual basis, but restoring flow doesn't necessarily mean they do very well, because a lot of people still have microvascular obstruction. And this accounts for most of the deaths or heart failure during STEMI. And of course, those with microvascular obstruction have a very high mortality rate of 7.5% at 1 year. And of course, for those with open microcirculation, at 1 year, the mortality rate is less than 3%. So maybe it's possible to assess microcirculatory resistance as well as an index, or whether or not it's still infarction going on immediately post-prime PCI, and potentially improve infarct size salvage. Microcirculation has been studied a little bit over the last few years, and we can see that it can be a prognostic factor post-myocardial infarction, particularly if it's significantly elevated. How do you measure that? Well, it is, of course, a pressure wire-based system. The pressure wire has a temperature sensor, and really, we only need the hyperemic measurement of distal pressure times the transit time using a quick injections of 3 mils of normal saline at room temperature. This is a resistance equals change in pressure over flow, much like R equals V equals IR, like Ohm's law. And of course, the change in pressure is distal pressure minus the venous pressure, which is usually 0. And the thermal dilution element is proportional to 1 over transit time of the flow of the saline. PV may be 0, so it's basically distal pressure times the transit time and maximum hyperemia. So elevated IMR post-infarct, prime PCI, can actually indicate high risk for events. This is kind of the quintessential Coraventous display you might find: FFR, PDPA, CFR, IMR. If you did the baseline flow curves at resting before hyperemia, you get a relative resistance ratio, largely describing the vasodilatory capacity of the microcirculation. IMR post-infarct, immediately post-primary PCI, can predict infarct size. It can also describe the likelihood of recovery. This is a wall motion score, and you can see it significantly improved with a low IMR, less than 32, in this study by BeFeron. IMR also predicts prognosis in STEMI, particularly IMR over 40 has been shown many studies, including the Oxford study, showing that IMR elevated more than 40 is highly correlated with microvascular obstruction and also poor prognosis post-STEMI. There's been a study here, this is New England Journal 2007, looking at intracoronary thrombolysis immediately after primary PCI for STEMI to improve myocardial reperfusion. And this is using streptokinase. Now, in this study, a subgroup analysis looking at also the end diastolic, end systolic, and EF and infarct size, there's significant improvement using intracoronary fibrinolysis, using STK. There's a larger trial called T-Time. This is a sub-study here. Notice in T-Time, an attempt at opening up the artery using either aspiration, thrombectomy, or balloon angioplasty, and reperfusion, and then randomized to receiving placebo, 10 milligrams of TPA, 20 milligrams of TPA, and then a stent. And this microvascular substudy looking at IMR and CFR, there was no difference between the randomized arms, but IMR was not used to triage treatment. In the major part of the trial, there was, which was the endpoint was microvascular obstruction, there was also no difference. But there were under 6 hours in the trial for STEMI, and in the subgroup of 4 to 6 hours, in fact, it shows perhaps an increased risk of microvascular obstruction and or extent of myocardial hemorrhage on cardiac MRI. The study I've been involved with locally with a couple of my colleagues, they've actually got a research grant from the National Heart and Medical Research Council of Australia to run a Restore MI trial called Restoring Microcirculation Perfusion in STEMI. And this looks at TNK, weight adjusted, largely because it's more fibrin specific and it is more resistant to breakdown. The hypothesis is that if we can actually use the IMR to triage treatment, we randomize people with elevated IMR with treatment with intracoronary thrombolysis and see if they improve. And the endpoint would be a cardiac MRI infarct size. This is a schedule, and this is a 506 patients planned, actually recruiting at the moment. IMR is measured immediately after successful primary PCI. If the IMR is less than or equal to 32, standard care in a registry. If you're over 32, you're randomized to either placebo, 1/3 of the systemic weight-adjusted bolus of intracoronary TNK, or 1/6 of that dose down a coronary guiding catheter, cardiac MRI in a week, and cardiac MRI in 6 months, and follow up for 24 months minimum. So this is the primary endpoint, infarct size as percentage of LV mass at 6 months, and possibility of intramyocardial bleeding rate, myocardial salvage index, secondary endpoints, and 6 hours within onset of symptoms for primary PCI, and consent to a cardiac MRI. Major exclusion is previous infarction in a territory or any residual 50% lesion in the culprit vessel or prior infarction in the target territory. The pilot study, which was performed by my colleagues, were published recently in JACC. And this looked at 88 measurements in 22 patients, and serial measurements of IMR, CFR, and RRR was done at 0, 10, 15, and 30 minutes post-primary PCI and treatment. And the mean age was 65, 36% were female. From symptom onset to presentation, 176 minutes. And geometrical mean of the IMR immediately post was 32. There was a significant decrease in IMR over time to 15 and 30 minutes. And the CFR increase also, particularly at 30 minutes, significantly higher, but already came up at 15 minutes. And the relative resistance ratio was significantly increased at 30 minutes. It suggests that the microcirculation is quite dynamic immediately post primary PCI. Each unit rise in IMR is equivalent to about 0.3% increase in infarct size, and every 5% increase in infarct size potentially associated with 19% increase in 1-year mortality rate. I'll show you a case we recruited. This is our second case recruited in the RESTORE-MI trial, 72-year-old male, anterior STEMI. We usually swap them with COVID as they come through the ED, anterior STEMI ECG, a circumflex lesion, and LED stenosis with some osteal lesion as well, although the artery is now patent at the index angiogram. We basically proceeded to wire and stent. I contacted the trialists because of the need to do circumflex PCI, and this is allowed. So we stented the circumflex artery. We stented the LAD artery. And then we stented a bit long, a little lesion here at the diagonal branch. We also fixed that. Result was negative for COVID, was rapid swab. And we did an IVUS to check stent expansion. And stent expansion was very acceptable. But we did notice there is an osteo-LAD lesion about here. We measure this at about, it's about 4 point, it's very reasonable size. So we thought we'd leave it, and we did IMR measurement. Notice that the FFR here is 0.76, suggesting ischemia. IMR was quite elevated at 69. We did a pullback, and you can see that this seems to be fairly focal at the osteo-LAD. So we decided to stent this left main to LAD and check the IVUS, which looked okay. However, a quick look at an RFR post-stenting of the left main was still 0.75. And interestingly, we think that we didn't know exactly which part of the artery was particularly important. So we thought that we'd leave the pressure wire in and actually just balloon areas we thought were stented and try to correct it. And on the mid-LAD, when we dilated, we corrected the RFR to 0.91. PDPA was 0.9. We then repeated the physiology measurements. You can see the FFR is now 0.9. The IMR is 54. And therefore, we could randomize to deliver the treatment. We don't know what the treatment was, but post-treatment, we can see the IMR is 49, slightly lower, potentially had placebo. This is a TIMI flows at the end of the procedure. So I'm going to, the last few slides, I'm going to talk about the reduced trial, which another colleague of mine, Professor Nagichi, is running at another hospital in Sydney, called Restoring Microvascular Circulation with Diagnostic Ultrasound with Contrast Agent. This is based on, of course, microbubbles and microspheres being able to be fractured using high mechanical index ultrasound. So if you inject this down the coronary artery, you may be able to explode these microbubbles and increase the probability of opening up the coronary artery if they have thrombus. This is called sonothrombolysis, ultrasound and bubbles. You'll need an ultrasound machine and delivery of contrast agent, usually echo contrast with microspheres, and inciting sonothrombolysis. This is the protocol, and the pilot study have been performed with 21 patients approximately in each of the 3 groups, including pre-hospital, pre-PCR sonothrombolysis and post. sham echo and post-PCI sonothrombolysis thrombolysis, and sham echo, and then MRI. These are the results of the pilot study given to me by Professor Noguchi. So he's happy for this to be presented, as he presented this previously at our annual meeting. You can see that the group that has pre and post sonothrombolysis did particularly well in infarct size percentage has been reduced by percentage LV mass. And also the myocardial salvage index is also significantly increased if you do this for primary PCI. So in all of this, maybe not tea time, but maybe it's time for coffee time. So I thank you for the presentation. Look forward to the discussion.
Thank you, Sidney, for this great talk and this overview and in IMR, FFR, IFR, in STEMI. Well, for me, it's a little bit. I mean, it's similar to the things that I did like 10 years ago with the myocardial salvage in dogs in MRI, and we tried to figure out how we can measure the myocardial salvage in these dogs and how to set up the best setting in these animal studies. And there were so many factors influencing even these animal studies, and it's getting more complicated in real life, in human. So you did a very sophisticated approach to measure all this stuff in your patient, but do you think that it will comes down in the end to one medication fits all approach, or do you think that we have to treat the STEMI patient and then do all the measurements and get an individualized precision medicine like approach in treatment in these patients?
So I think the questions I have to tell you is that we don't know. We're definitely studying the microcirculation post-infarct, and we're surprised by how dynamic it is. We're surprised, we don't know if it affects all the microcirculation, not only of the infarct artery. We think it does, because Michael Gibson's old studies looking at TIMI frame counts where non-culprit vessel also has reduced flow during the STEMI. So we expect the whole microcirculation is going bonkers up and down all the time, and we don't really know, we can't quantify it, how much, how quickly. We do know it recovers, and we see some very early indication it can recover very quickly during this. We're not sure it's related to treatment. So it'd be interesting to see if it's one drug, maybe it's not even fibrinolysis. There in tea time, it is interesting. We've watched it very closely because we're worried about the myocardial hemorrhage. We worry about bleeding rates. And it was unselected, and so we don't know. And of course, if we get to people early, we hope that we're doing even better. So it's a proof of concept, I guess, at the moment. And notice that they've also reduced that 1/3 and 1/6 dose, maybe to broker this a little bit more, a bit of dose finding in this current study.
Right. Thank you.
Okay. So,
I think we get.
Yeah.
Excuse me.
Yeah, I think I saw there's two panelists trying to ask some questions. Maybe Jonathan, you ask first. Maybe we can maybe just allow two questions. I saw there's two hands raising. Jonathan, go ahead.
Thanks very much, Alan. Thanks very much, Sidney. I think that's an excellent presentation. I learned a lot from your talk. But I do have one question about the flower MI study, which I think it stirred quite a bit of controversy since it was published. I'm personally a big fan of like a functional study like FFR, IFR in stable ischemic heart patients. But while they're doing that in like that STEMI patients, like, do you think it makes a difference whether they do the FFR, IFR at the index procedure or when they bring the patient back in a few days when the patient is actually cooled down? Because I think like doing FFR, IFR at the index procedure, I'm not sure it really accurately predicts or reflects the true functional significance of a non-culprit lesion when the patient is actually pretty heated up in terms of like acute STEMI, inflammatory phase. Like, would it be better if we actually bring the patient back in a few days, try to complete the procedure under FFR, IFR guidance instead of doing it in an acute stated?
I'll agree with you. I think the accuracy of physiological measurements would be like the IFR and FR comparison. I think it's more accurate the further you're away from the index infarct. As I mentioned, I think that flow is reduced in those other vessels. So if they were not so ischemic, like in flower MI, they didn't appear to be necessarily very ischemic, only 55% actually had FFRs less than 0.8. The question really is that were they just unlikely to be ischemic in that? And we don't know. I think overall, many other studies have shown that I think the longer you're away from it's more accurate and will still give you a very good indication because they're comparable to being stable if they were ischemic, kind of like needing to be revascularized. Totally agree.
Thank you.
Do you
Tamara?
use do you use this in your regular PCI day, Sidney?
Currently, no. It is currently in the study, so we're putting infarcts in the study. So it's not routine care, of course. Yeah.
Okay.
Really wonderful presentation,
Right.
Sidney. My question is very similar to Jonathan's. You know, when we have STEMIs, obviously our primary concern is door to balloon times. And so we want to be as comfortable as possible with our workhorse wires and so on. So when you're doing a STEMI, when is the right time to throw in an FFR wire and start doing your measurements? Are you doing that after you achieve flow and, you know, your workhorse wire is the one you're most comfortable with? So just a very practical point here.
Absolutely. So totally agree. So basically the study was primary PCI. So actually you don't even get into or remotely need a trial till you finish your primary PCI. Sometimes when you do the physiology in that case, you think you haven't really completed an optimum PCI because normally you expect to be negative anyway if you had a significant infarct, and yet you're very, very positive, like 0.75. You think, maybe it's a bit more ischemic than you know. So you have to sort of complete that more properly now that you have an index that tells you physiologically that you probably haven't achieved the optimum result. But yeah, normal. I think the pressure wire only gets in after you finish your primary PCI.
All right. I think we need to move on because we still have 5 more presentations. Thank you. I think Sidney very much for it's very thought-provoking. I always learn something from you. So may I ask the next speakers, Dr. Lucio T. I think he's ready after settling the technical issues. So
I'm ready. I don't know if you are here.
Right, excellent. We can hear you. So
Perfect.
we also see your slides. So today, I think you are going to show us some of the information of the imaging, intravascular imaging, in particular IVUS in STEMI PCI. So Lucia, go ahead, please.
I choose this topic in order to ask you if we use IVUS in bifurcation lesion causing a STEMI. This is a very regular case. This is a case of a male, 58 years old patient with atrial fibrillation that he comes with an anterior STEMI. He was with his regular apixaban, rosuvastatin, carvedilol with a very high troponin. And this is the angio, no? Here we can see that we have in the left the distal left main lesion, the ostial LAD lesion, the circ LAD lesion, less than 70. Here and here in the right, we have the LAD lesion. We can see a bifurcation of a very big diagonal branch, big as a lung, but it seems to be not too big. So this is the question, what we can do here, and if we do some imaging or not. So this is the approach, the initial approach in a bifurcation, 2 wires, the diagonal branch open, the LAD open, but here it seems to have some thrombus. So I did pre-dilatation of LAD, the diagonal was occluded, so I do a kissing, and then this is the first result. So without stent, this is the first result. But what about what we can do? We can do an angio assessment, only that, or we can do something different. First of all, if these are complex bifurcation or not, yes, side branch more than 19, thrombus containing, more than my classification, bifurcation less than 45. And what regarding the left main lesion is less than 70, and the side branch is 50, no more than that. So it seems to be a simple lesion. So it seems to be for left main LAD a provisional stenting. And regarding if we need to do 2 stent for this type of lesion, we try to do a side branch stent first as a decay crash. But always doing IVUS or OCT strongly recommended after the left main stenting. Here is something about, what about this case? No, side branch bifurcation. What about the thrombosis of stents predictor? STEMI is okay, bifurcation is strongly, stent length and number of stents is more for stent thrombosis, overlapping stent more. And what about epidemiological data about STEMI? Bifurcation versus no bifurcation. The prevalence is between 10 and 15%, but they have similar MACE rate and similar stent thrombosis rate. What about the treatment? One stent or 2 stent techniques? We are going to see that, but the angiographical success is similar in this scenario. What about the Medina classification? Most of more than 50% here at the right, I can show in the Latin bifurcation registry that we have near 50%, and in the world is like this. What about the STEMI in bifurcation? Most of them in LAD. And what about this stent thrombosis? Stent thrombosis, it seems to be a little more in this scenario in bifurcation, but all the MACE not have to be different between bifurcation and non-bifurcation. What about 1 stent or 2 stent? It's better to have a provisional stenting in this scenario. And in conclusion, bifurcation lesion in STEMI should be approached in the same way than bifurcation lesion in other clinical contexts. So always widen the side branch, prioritize provisional stenting whenever possible. And here is the topic, IVUS assessment if possible. Why? So here, if we have to do 2 stent technique, minimize overlapping, bootstrap the position, and whenever possible, longer tap. Why about IVUS? Why IVUS assessment in complete patient give us the information? And this is a complex patient, and this is a daily patient. Why we have to do IVUS in this type of patient? Do IVUS have anything that give us more information? Yes, we have the vessel diameter, the vessel angulation of the bifurcation, the plaque characterization, and what about the side branch access difficulty if we have to do a pod, key spot, whatever. So here in the Latin bifurcation registry, over 1,000 patients, 11% are STEMI, and here 82% is radial approach. But look at this, which is the use of intracoronary imaging, and this, what about IVUS in non-unprotected left main? 18%, no more than that. What about OCT? Very low, 0.7%. FFR, EFR, 1.8%. And what about unprotected left main? IVUS, 56%, but not 80 or 90. This is Latin BIF registry. What about this case? What about the IVUS information in this case? It seems to be, well, and it seems to perhaps to put a stent in LAD and no more than that, and nothing to the diagonal branch and doing only, and this imaging is after TC balloon, LAD, and diagonal branch. As you can see here in the LAD, we have by IVUS a concentric soft plaque with a MLA 3.2. This is severe. And here we have the culprit lesion with an eccentric plaque with some thrombus. And here it don't seem to have a lot of thrombo by angio, but the IVUS shows something different. The diameter here is bigger than we look in the IVUS. And here we have an eccentric calcified plaque where I don't see that. And what about the diagonal branch? After the predilatation, we have an eccentric plaque with severe lesion. So the IVUS changed me something, yes, it changed me the conclusion. The distal AD is 3.4, proximal AD is 4, left main is 5, diagonal is 2.5, plaque catheterization, curve relation, soft plaque with thrombus, and eccentric soft plaque in the diagonal. So what IVUS shows in different trials is reduced 3-year mortality using IVUS and not using IVUS as guiding PCI. And this is perhaps the more recent information that I have been talking with a friend, is Mamas, the impact of intracoronary imaging guiding percutaneous coronary intervention and procedural outcome. And this is something that we have been chatting with Mamas 15 years ago, having an assault in my house. And he told me that in England and Wales, between 2014 and 2020, over 555, so a lot of PCI, only 10.5%, so that is to say near 60,000 patients of these have intracoronary imaging. So you can see here, IVUS from 2014, 7.8%, 2020, 17%. So it's not 40, it's not 50, it's not 90, it's underuse. Where? So what is the prognostic, the utility of IVUS guided over this population, 500, near 600,000 patients, MACE in left main PCI, in acute coronary syndrome, and in stent length more than 60 millimeters, we have MACE if you don't use IVUS. So what about the all-cause mortality? What about the mortality, intra-hospital mortality? If you use IVUS, you reduce in stent thrombosis PCI, in left main PCI, in acute coronary syndrome, and in stent length more than 60. So here you have the conclusion is that you can reduce using the prognostic utility of IVUS. You can reduce MACE, most in left main, acute coronary syndrome, and intra-hospital mortality in acute coronary syndrome. But which is the percentage is underuse. This underuse, as I show you, this is 9% of the all PCI in acute coronary syndrome. Yes, this is in left main, 41%. This is England and Wales, no, 7 years. And this is in-stent thrombosis and stent thrombosis. So it's not a lot of IVUS or imaging guided PCI. So this is a very important thing for me. What technique will you use in this scenario? So I have this angio, but I have the information of the IVUS. So here I have a lot of plaque in the osteal lesion. Here I have a lot of plaque, a residual plaque after post-dilatation, an aggressive post-dilatation or pre-dilatation. So will you use provisional, DEB, culotte, crash, mini crash, nano? So in this scenario, without IVUS, perhaps I'm gonna do a drug-eluting balloon here and only a stent here. But with the IVUS information, I changed my mind in order to say, no, I have a residual severe stenosis, a very extensive diagonal branch, and I have a very big artery here. It's not only a small. So what I do here is here you can see the stent pullback technique, and then here is the second stent in the LAD. This is the angio result that we have here. And if you don't have IVUS, you can use this one. So I ask you, do you use STEMBUS or STEMBIS as in a guided PCI? So here you can see if this is underexpanded or not. What about the ostium of the diagonal branch? So this is another tool that we can use, and you can see a lot of calcified plaque here in the proximal. So do you use this tool or not? So this the result, the case resolution, and then regarding the left main, only a provisional stent to LAD, left main LAD, POT, and this is the final result. So after the PCI, pre and post PCI, the long view IVUS. So the take-home message for this in acute myocardial infarction PCI, bifurcation PCI, the prevalence is 10–15%, similar outcomes than non-bifurcation, lesion causing STEMI, two stent technique, more risk of stent thrombosis and TBR. If IVUS, if possible, for consider vessel diameter, angulation, plaque catheterization, side branch access difficulty, and PCI guided can assess us a lot of information to modify the plaque optimization, to use stent boost if you don't have this type of tool, provisional stent if possible, and underuse IVUS guided PCI in this scenario, and IVUS PCI reduce intrahospital mortality, where in left main PCI, in acute coronary syndrome, in stent length more than 60, and in stent thrombosis. So thank you very much, and we can conclude this topic.
Okay, thank you. So I think as always mentioned, imaging is particularly important in complex subset. I think in AMI setting is highly relevant and also can greatly reduce the long-term MACE event. So before I ask a question, I think I saw two panelists raising their hands. So Vinci, so you're going to ask something?
Yeah,
Yes.
hello everybody. Hi, and congratulations to Dr. Padilla for the nice presentation. Now, I have a question. So we all know that when we use intravascular imaging, we tend to use bigger stents. So we go higher because we see the real dimension of the vessel. Now, in the setting of acute coronary syndrome, especially STEMI, we know that if we go higher with stent and if we go higher with balloon, we increase the risk of slow flow because of mechanical distal embolization of the plaque. So what is your idea about just restoring the flow in the acute setting, maybe putting a stent in and then bring the patient back for a second procedure after a few days in order to optimize the result with the use of intravascular imaging?
In my experience, Vincenzo, I try to use 0.5 millimeters less than IVUS show me the diameter, and not do more than that. There are a lot of cases with positive remodeling, there are thrombus, so not to do more than that to restore the flow, as you say, but I can leave an infra-expanded stent in a thrombotic lesion. So that is a very good tool, and this IVUS not only is under use, but it gives us a reduced intrahospital mortality, as Mama shows recently. So if we can do it, we have to use not only IVUS, OCT I think is better for this type of scenario. So I think we are using less than we think. And the other take-home message is that IVUS reduce intrahospital mortality. So in this scenario, in acute coronary syndrome, in left main, in stent restenosis, stent thrombosis, these are different topics that we can have a benefit.
I think imaging give us a lot of more information than we expected. I think Dr. Lucio highlight the importance of, for example, you get a bigger stent size. And I think from my perspective, more importantly, he tried to able to let you know the extent of the atherosclerosis, particularly the run row plaque. You are going to cover up with a stent, just not going to leave the so-called the geographic miss. And this can be have a long-term sequelae resulting in, for example, late stent failures, late stent thrombosis, etc., etc. I think it's particularly important why the imaging can give us the extra benefit. And of course, the matter of debate is whether will you push the limits of the vessel size using the post dilatation limit. But probably more importantly, especially when you're taking the more complex AMI situations, just like this case shown, but you need to go ahead for bifurcation, stenting, probably really imaging will try to reduce the so-called risk of long-term stent thrombosis. So I saw Jian-Ming as well as Chris has questions, but maybe we can anything, 2 quick questions from both of you.
Thanks, Alan. Great presentation, Dr. Lucio. Maybe just a couple of comments. I thought that the IVUS would be very useful, especially in the setting of ECS from a stent thrombosis, for example, or in the setting of a bifurcation lesion. One branch is occluded, the other one is not occluded. And you might be able to use IVUS to evaluate whether there's any differences between the 2 branches, whether it's due to a previous malposition or any technical factors that can explain the clinical presentation. The other comment is that in your study, it looks like IVUS was overwhelmingly used in preference to OCT. Not too sure what the reasons could be, whether other panelists can further discuss this. Maybe because in an acute setting, you just want to quickly get a procedure done. And for IVUS wise, you don't really need contrast clearance. And IVUS seems to be more readily available compared to OCT. Welcome other views from other panelists as to why IVUS could be much more commonly used in the setting of ACS.
Do you use intracoronary imaging in the daily use, as I showed here? Is underused in Asia, or because we also in all the webinars we show a lot of very nice cases with IVUS, OCT, blah blah blah. But do we have the underuse percentage of using intracoronary imaging as I showed this, or what is Asia numbers? Do you have that number?
It's an interesting question, Dr. Lucio, that you mentioned. I think the use of imaging, intracoronary imaging, whether it's IVUS or OCT, is still quite variable. But since we are in the context of talking about imaging in acute setting, more commonly when I use imaging will be, especially when there is a presentation of stent thrombosis, for example. You want to explain whether there's any technical factors related to the stent. That's one striking use. I don't think I routinely use IVUS or OCT for every acute case that I do.
So yes, I think there's two questions to the lots of Lucio answer. So in Asia, I think the penetration of imaging is quite high. So it depends on where you come from. For example, in Japan, I think they're close to 90%. In Hong Kong, I think it's more than 80% for most of the centers. For the rest of for example, Singapore, Malaysia, I think I need to input from some of the panelists as well. But for Southeast Asia, most of the country actually have a very high utilization rate. So to fit in the question of using the imaging in STEMI, so the practical tips is usually we are still rushing. I think aiming for a quick reperfusion time. We are not going to use the imaging at the very beginning, but most probably is after we establish a flow for a practical point of view. Then you have more leisure, the patient get more or less saturating EKG resolve, and then probably it's time for you to further assess the lesion. I think usually it's right after the immediate reperfusion. You can, of course, take out your imaging after you put in stent to further optimize it, but probably the key is still to reperfuse the vessels. So, Chris, you for the final comment on this?
Yeah, sure. Thank you, Lucio, for this great talk. So the numbers of using intravascular imaging in acute settings or even in a stable setting is picking up in Germany and Europe, but it's still, in my opinion, too low. But anyway, I think it's important to do it on a daily basis. And if you do it routinely and easily with your team, you can set it up in a couple of minutes and just do a quick run. And then the limit to do it in an acute setting is very low. The threshold is very low, so you can easily and routinely do it even in an acute setting. There's one question from the audience that I would like to ask you. Dr. Abid asked for what is the incidence of no reflow in bifurcation PCI, and especially in left main bifurcation PCI that you observe. And you're like one of the PIs of the LATAM bifurcation club, so you probably got some numbers to it, right?
Yes, in unprotected left main and in non-unprotected left main, we have a 3.5 no reflow in our data, but this number in all the Latin BIF registry we have only 10.5% of acute coronary syndromes like this. So this is perhaps a number that is not too big, but this is our reality nowadays.
Right. I think the incidence of no reflow in bifurcation PCI or in IVUS there is pretty low. It's certainly higher in acute setting, but still it's very low, especially in the experienced hand with the proper precautions. Thanks again, Lucio, for this great talk. And I was in STEMI, and I would like to introduce our next speaker. It's Dr. William HAU from Hong Kong, giving his talk on the role of intravascular imaging in acute myocardial infarction. Dr. HAU.
Okay, can you hear me?
Yes.
Okay, can you see my slides?
Yes, yes.
Okay, actually, in my talk, I'm going to give you some answer of the question you just asked before. Actually, now I'm going to talk about the role of intravascular imaging in AMI. In order to understand how and why invasive imaging can be very useful in AMI cases, I think it's very important for one to understand what are the underlying mechanisms on causing an acute coronary event, and especially in the understanding the concepts of vulnerable plaque. So what is a vulnerable plaque? Vulnerable plaque is a high-risk plaque that is prone to rupture, and is also the most common cause of sudden cardiac death. Currently, where at least 3 types of vulnerable plaque were identified by the pathologist. The first type is a thin cap fibroadenoma TICFA, which consists of thin fibrous cap, less than 65 micron, with a large lipid core. And the second type of vulnerable plaque is a erosion plaque. That's a platelet-rich white thrombus with intact fibrous cap. And the third kind of vulnerable plaque is a calcium nodule. Among these 3 vulnerable plaques, thin cap fibroadenoma TICFA is the most dangerous one, as which is the pathological substrate underlying up to 70% episodes of acute coronary syndromes. The concept of the vulnerable plaque has been developed largely by histopathological studies of populations in patients who have died from acute myocardial infarction. Retrospective pathologic studies of plaque rupture with thrombosis have suggested that prior to the thrombotic event, the plaque was an inflamed thin cap fibroadenoma TICFA with the following features: a thin fibrous cap less than 65 micron, contains a large lipid-rich core, presence of inflammatory cell and necrotic tissues. Inflammation of the cap by macrophage further increases the vulnerability, and also with positive remodeling. And IVUS is very useful to quantify the degree of positive remodeling. TICFA has a lipid core that extends into the vessel wall and is only covered by a thin fibrous cap. So once ruptured, we release the thrombogenic core of lipid and necrotic TP into contact with the bloodstream, in which leading to thrombus formation. So is there a role of invasive imaging in the primary settings? Primary PCI is always targeted on the angiographically identified corporate lesion. However, the actual corporate lesion may not compromise the lumen and can be located proximally or distally to the angiographic target lesion. And as a result, the risk of incomplete lesion coverage can be high when the primary PCI is guided by angiography alone. And also, stent implantation must be optimized, as incomplete apposition and or edge dissection may result in instant results or acute thrombotic events. Invasive coronary imaging using IVUS or OCT can be useful to guide primary PCI by locating the true corporate lesion and may lead to better stent coverage of the lesion. Besides, invasive imaging like IVUS or OCT can also help to resolve diagnostic uncertainty and to identify the mechanisms underlying the acute events. So currently in the market, we got two invasive imaging modalities. We got IVUS and OCT. IVUS can penetrate deep into tissue, allowing visualization of lumen, entire part burden, and vessel wall. However, the high resolution of OCT provides superior delineation of the superficial structures. So if you want to see the deep structure very clearly, you should use IVUS. And if you want to see the superficial structure very clearly, then you should use OCT. And honestly, OCT is very useful in identifying vulnerable part. So this is the thick fur on OCT. So we can see the thin fibrous cap, less than 65 micron, with a large lipid core. And this is the erosion part on OCT. We can see the patented rich white fungus with intact fibrous cap. And this is the calcium nodule on OCT with an irregular surface casting dorsal shadows. And right now we have a study from China, Harbin, the erosion study. It shows that in ACS patients, due to plaque erosion, anti-thrombotic therapy without stent implantation effectively reduce the thrombus volume and is able to increase the fold area without the reocclusion of the copulation at 1 month follow-up. And up to now, the OCT is only technology allow us to differentiate plaque erosion from rupture plaque, not IVUS. So this is a plaque erosion on OCT. We can see the patented rich white fungus with intact fibrous cap. And this is the rupture part on OCT. We can see the thin fibrous cap will rupture here. We also have IVUS studies show that rupture plaques were able to heal after 22 months of conservative medical treatment. So in this study, they recruited 14 patients with 28 rupture plaques. And the minimum lumen area is more than 4 millimeters square, and all undergo conservative medical treatment. And the result of this study shows that 50% of the rupture plaques healed and the degree of stenosis tended to reduce. And no clinical event related to a lesion under the study period. So for rupture plaques, if the blood flow is good, and if the IVUS MLA is more than 4 millimeters square, conservative medical therapy without stenting can be a viable treatment option. In this single-center proof-of-concept study, it showed that in selected patients with ACS, a two-step strategy without stenting guided by OCT is feasible and safe. And through this approach, may avoid systematic stent implantation and allow medical therapy alone. So step one, optimal reperfusion during index primary PCI, and that includes fibrinolysis, thrombus aspiration, small balloon angioplasty, and or gyrotropin 2B3 inhibitor therapy. And then step two, repeat angiography and OCT a few days later, let's say 3 days or 5 days later. In case of absence of vulnerable part rupture and stenosis less than 70% on OCT, go for medical therapy treatment alone without stenting. And the result of this study shows that in the follow-up OCT, it showed that a significant thrombus volume reduction, MLA enlargement, and a decrease in percentage stenosis and lesion length. The use of invasive imaging like OCT may help us to understand what are the underlying mechanisms or factors that contribute to stent thrombosis. And accurate diagnosis for the cause of stent thrombosis, I think, is very important in order to implement appropriate therapy. So in this national French registry, based on 122 patients with stent thrombosis, OCT is used to explore the characteristics and underlying mechanisms on causing stent thrombosis after optimal thrombus reabsorption based on a two-step approach. And the result of this study shows that STEMI position and neoepinososis rupture were the main causes of late stent thrombosis and very late stent thrombosis. And also the result of this study shows that STEMI position and stent underexpansion were the prominent mechanism for acute stent thrombosis and subacute stent thrombosis. Intramural hematoma. SCAR, spontaneous coronary artery dissection, is a rare cause of acute myocardial infarction and is due to a spontaneous separation of the intimal media layers associated with intramural hematoma rather than plaque rupture or erosion. Angiographic diagnosis of scar can be challenging, and the use of invasive imaging is very useful for diagnosis confirmation. If you are familiar with scar, then you know that, okay, this is a class 2B by Jacqueline source scar definition. So we can see that the dissection extended to the distal tip. And let's take a look at the IVUS. So on IVUS, the key is to find the media. Let me stop the IVUS here. Okay, so pay attention. Okay, so now we can see the media. So once you're able to find the media, then you know that your IVUS is in the true lumen, and this is the false lumen with the intramural hematoma. So we can see blood accumulate in the false lumen and caused by the speed in the media and to become static and echogenic. And IVUS allows a more complete and deeper visualization of the stent of the intramural hematoma. And this is a corresponding OCT image. So let's take a look at the OCT. So on the OCT, we can see the presence of crescent-shaped false lumen. And OCT may help to identify intimal tear if there is any. So invasive imaging like IVUS OCT can help to identify the true lumen and false lumen with intramural hematoma. So in case if PCI is needed, invasive imaging is going to be very useful to help us to select the stent size and length, because angiogram is not able to tell where the scar begins and where it ends. If the stent is too short, we may propagate the dissection and make the situation even worse. So right now, a positive study shows that use of invasive imaging is associated with a larger final in-stent minimum lumen area, utilization of lesser stents, and resulted in better clinical outcomes. However, we also have negative studies shows that use of invasive imaging is associated with more and longer stent use, but with no improvement in clinical outcomes. It only increases overall procedural time and costs without adding too much benefits. And the reason why we got discrepancy results in here, I think, can be because of the use of different IVUS OCT stent selection and optimization criteria, and can also be because of the use of different generation of stents, and can also be because of the use of different DAPT regimen in different studies. And honestly, if you ask me, I think in the settings of primary PCI, invasive imaging use can be a two-edged sword. If used in good hands, invasive imaging can help in stent implantation guidance in terms of proper stent size and length selection and post-implantation stent optimization. And as a result, may result in reduction of resources or stent thrombotic events. However, it may also be associated with a higher rate of chronic complications. And this could be because of poor image interpretation due to a large thrombus burden in the population of ACS patients, making it rather difficult to determine proper stent sizing and optimization of stent deployment, and resulting in under or oversized stent selection. And this may have a disastrous consequences like dissection, perforation, or stent thrombosis as well. So as a conclusion, ladies and gentlemen, I think invasive imaging techniques like IVUS and OCT provide complementary details to help primary PCI guidance, such as in identifying the underlying mechanism of the acute event, ensuring stent coverage of the population, and optimization of stent implantation. OCT is superior in the visualization of superficial structures, such as TICFA, thin-cap fibroadenoma, plaque rupture, plaque erosion, stent edge dissection, intimal tear, tissue protrusion, and intraluminal thrombi, whereas IVUS is better for deep vessel imaging, like vessel sizing and identifying positive remodeling. Use of invasive imaging like IVUS OCT can potentially help to tailor-make treatment strategies on the management of patient ACS. Conservative treatment with anti-thrombotic therapy without stenting seems to be a reliable option in selected patients. And besides, invasive imaging like IVUS OCT can also help to resolve diagnostic uncertainty and to identify the mechanisms underlying the acute chronic events. However, it remains controversial as to whether routine invasive imaging guidance improves outcome in patients receiving primary PCI. Thank you for your kind attention.
Thank you, Dr. HAU. I'm always impressed by your thoughtful and thorough presentation on intravascular imaging. You covered so many things we can talk about. And I would like to invite Dr. Lee to join the discussion on these points.
Well, thank you very much, Christoph. William, it is always a pleasure to hear you speak. I think you've covered the topic really well. I just have a comment as well as a question to make. I think for me, the use of imaging in patients with STEMI is, of course, really important. You did touch upon whether they should be routine. I personally think that it should be. I think many a times, if we would use imaging often enough, you would realize that what you feel, maybe the angiographic lesion, would turn out not to be the case. A lot of these culprit lesions whereby the plaque rupture has happened is actually quite remote sometimes from the area whereby you feel is angiographically more significant, especially if it's a pharmacoinvasive procedure. And some of these patients have undergone a fibrinolytic therapy to begin with. I saw that you have made a statement that leaving plaque ruptures behind are potentially acceptable. I'm just going to ask you a question that is also quite controversial. Now, I just wish to get your thoughts about the role of prophylactic stenting of vulnerable plaques in the context of some of the more recent trials. The real question is, we pick up a lot of them. We don't really quite know what we should do with them. Clearly, you're a proponent of just leaving some of these plaques behind with medical therapy, but just to hear your thoughts on this particular subject matter.
Okay, now when it comes to rupture plaque, I think if angiographically the flow is good, and if you do IVUS, the MLA is more than 4 million square, then I think it should be really safe to defer stenting on this kind of lesion. But of course, if angiographically the flow is not good, and the MLA is very small, then I think probably should go for stenting. I don't know what the other panels for. Yeah.
Yeah, I think this issue is becoming more complicated nowadays because we have increasingly good in pharmacology. It's not just pharmacology, but it's interventional pharmacology. We have so great lipid-lowering medication nowadays. So I think when you're going a lots of these general cardiology conferences, the so-called PCSK9 era actually transformed the care of the coronary artery disease. So much so that many of them, even the so-called the round plaque, the T5, etc., can be stabilized medically. So the traditional concept of plaque rupture, plaque sealing, I think this concept more than 10 years ago has been repeatedly challenged by a lot of negative studies. And basically, I think nowadays, I understand that probably this is correct. So medical treatment still have the main role in reducing the overall the atherosclerosis progressions. So I think the plaque rupture, in particularly in all this acute coronary setting, is just a point of manifestation of the underlying disease. So if you just use stent to treat the disease, I think it's not the right way to go. You still need to treat the underlying risk factors, atherosclerosis, and at the end of the day, is the hyperlipidemias. So much so that it can really transform everything. So we also have more evidence of so-called plaque regression, and then the plaque get less, some kinds of remodeling. So much so that it's, at the end of the day, stenting may not be the only answer in treating coronary disease.
Yeah, if I can interject here, I think I would completely agree with Alan's comments. I think there's no trial to support the role of preemptive stenting for non-flow limiting plaque. I think Prospect Absorb looked at the use of BRS in this cohort, and there was some positive signal in terms of luminal gain after I think a year, but certainly no clinical endpoints for us to base our treatment of stenting for these non-culprit lesions. And I think, as Alan mentioned, PCSK9 inhibition in the Huygens trials, Glaglove trials, that has been shown to reduce lipid burden, increase fibrous cap thickness. So, that's probably the way to go, I think, at the moment.
Right. So maybe we can see the last question from Jianming before we go to the next case.
Thanks, Alan. Great talk, Dr. William. I just have a question to ask regarding the slide that you showed on the spontaneous coronary artery dissection. Any concerns with using the OCT in the case of SCAD? I mean, is there any concern like propagating the dissection, for example?
Okay, you asked a good question. So honestly, I think when it comes to scar case, IVUS is a better technology. The problem of OCT is you need to flush before you get a good image quality, and you may potentially extend the scar. I don't know what the other panel for, but honestly, I think IVUS should be a safer technology compared to OCT when it comes to intramural hematoma case.
Yes, I use both most of the time in cases suspicious OCT. I'm pretty confident using OCT, but of course, there's always all the colleagues always have the a concern about the negative effect, progression of the analysis. But yes, you should bear in mind. But probably is still safe in most of the cases.
I would like to echo Alan. We also use both IVUS and OCT in SCAP, and so far all the cases safe. So probably both imaging technologies are okay for SCAP. Okay.
All right. So I think time is running short. I think we need to move to the next one, which will be a little bit different from a pure case presentation. Is by William HAU again. The main driving force of the whole event is a record-like case. So I think he is going to show us something real. So, Ho LAM,
thank you.
Ahead,
today I'm going to share a live case to demonstrate how to use IVUS in AMI. The case was very simple. A young man with Welland syndrome with good LV function. So we go to see the live. ACS, you can see the critical proximal AD lesion. There's some disease over the circumflex, but it's okay. We can see critical AD lesion. And also there's a bifurcation lesion over the mid AD. The also diagonal seems quite tight. The proximal AD lesion was very tight. That is the culprit, I think, because the patient presents Welland, dynamic T inversion over anterior leads. I'll say also disease. So essentially, this is a triple vessel disease, and with ILA over the AD. So we wire both sides, and then this was the image. So maybe we let the panelists to comment what is your approach, how to use IVUS in this sort of case. Anyone would like to comment?
Any comment from the rest of the panelists? We have a few panelists here.
Hi, Lam. Here, Lucio. I think the IVUS is a very good tool in this case because you have from the osteal LAD and you have a very big diagonal branch and you can improve the results. And trying to do, if possible, provisional stenting in the bifurcation and then to choose the correct size and plaque preparation in this type of PCI, complex PCI. So I will try to do nitro, then IVUS to LAD to diagonal and see what about that. And then to choose the correct plaque preparation and to choose the correct stent for LAD and trying to do in the diagonal provisional if possible. And if I have a good result, less than 30%, no dissection, no TIMI3, less than TIMI3, drug eluting balloon there, if possible.
Thank you, Dr. Lucio. So how I approach...
Another comment, Dr. Lam, is that there is clearly diffusely diseased LAD. So when choosing the landing zone, I wouldn't be very strict in terms of choosing a part of the vessel with less than 50% plaque burden, as the consensus says. So that would be a good compromise. I think I wouldn't be very strict in selecting the landing zone, maybe go a little bit lower with the stent.
Thank you, Dr. Vincenzo. thank you for your comments. That is also what I'm thinking. So we want to use the IVUS. Always remember, IVUS is an investigation. We want to use this investigation to alter our management, or say to guide our management. So when we consider to do the IVUS, first of all, in our mind, we must know that what are you going to see? What is the most important finding? What is the most important thing? For this case, we know that first, the most important, we want to know the landing of the LED. So our IVUS is to find the landing of the LED and also find the length and size. For the diagonal, we also want to know the landing of the diagonal and also to assess this bifurcation to see whether we can use provisional approach or two-stent strategy. So we must know the primary aim of our reason to do the IVUS, and before we proceed. So let's see. And before all this thing, usually after wiring, I will go to check an angiogram, make sure the flow is okay before I do the IVUS, because after all, in all the AMI, the most important thing is restore the flow. If flow is unstable, we will restore the flow first before we do the imaging. Like this case, if the flow is okay, then we go straight forward for imaging. We first want to know exactly the landing. So we try to use the IVUS to search for the distal landing. That is the most important thing. In my habit, I will try to search and then find a good position. I will take a Sidney, mark the position, and then do a pullback one. This IVUS actually can do a quite fast pullback, and then we can have all the record on the length and size of the whole vessel. You can also have a very quick impression on the calcium and the PAP over the whole vessel. After that, I will use live mode or sometimes record mode, slowly pull back to precisely find the position of landing. Now, here is a good landing. So I always Sidney to use the IVUS marker to mark the landing site. That's very important. After marking the landing site, you don't need to take the full. You just move your IVUS catheter, then you can see the lesion. Only when you want to know what is the marker, where is the marker of the IVUS, then you take the full. For example, like here, I see here is the bifurcation, and then I use this marker to see, and then I take the full, I know. And then I have a gross impression on the part nature, the burden of calcium and everything. So that is the purpose of me to do the IVUS. If I move the IVUS all around, then I can see more. So for the diagonal, again, I found the distal landing. I will bookmark it, mark it, and then do an auto pullback. And from this auto pullback, I can take the length from my marking to the ostium. So, and then I will do the second one and make sure I won't miss anything. It's a gentle pullback, slow pullback to review all the part, all the lesion. And now I can see the bifurcation. The ostium of the diagonal actually is very tight. And the part burden at the proximal part is also heavy. So there are high risk of part shift, and the ostium of the diagonal is very tight. So we have to two-stent surgery. Although in angiogram, we may not be very sure, but in IVUS, we are very sure. And then I know all the thing. I know the distal landing of the diagonal and also the AD. Then I can just balloon it. Pedilate, make sure it's full expansion. And then also open up the critical lesion over the proximal AD so that when I pass through balloon to stent, it won't occlude the fold. So now I exactly know the landing of the diagonal. So I put the balloon in the AD first. I choose nano crush in this case. So from the IVUS, I already know the length of the stent in the diagonal. Also, they will help me to calculate the length of the stent in the AD. So I can just follow the IVUS finding. I put the stent in the diagonal. You can see that actually we don't need to inject a lot of contrast because we already know the length, everything, and then move a little bit. Okay, this is a good position to land the stent. And it's very important if you want to do the crush, you need to high pressure the ostium. This time I used the stent balloon to high pressure at 16 atm. Make sure the ostium, the stent at the ostium can be opened, and then use the balloon to crush. The balloon I choose is according to the vessel size in the distal AAD. So this time I keep the wire because I know this small balloon will not trap the wire. And in most of the time, you have to remove the side branch wire in order to avoid the trapping of the wire. So we put another stent. So we had calculated the length of these stents. We calculate precisely just below the septal. There's a septal. We calculate exactly from here below the septal and then to the distal landing. We have already marked it with previous IVUS, so we know where is the distal landing, where is the proximal landing, and what is the length in between. And then we can quickly put in the stent just below the septal to avoid stent overlap at the septum. And this time we do the IVUS again to check if our landing is correct or not, and also can measure the length. If I want to put the second stent, I know exactly the length. By this auto pullback, we measure the length at the same time. We always do 2-1. The first one is for the measurement, quick review, and also a slow pullback one. And then we found the landing of the stent was very good. And according to the IVUS, we already know the length of our second stent. So we put our second stent, we know the osteo AD also get some disease. So we have to land exactly. And we know exact length between the edge of the stent. So we can calculate the stent length exactly, so we can put the stent and make sure there are minimal overlap of stent, and it's quite accurate. As you can see, it don't occlude the shirt, and we know the size of the vessel, so we immediately can do the high pressure ballooning. Usually after this sort of stenting, I will do the high pressure ballooning. For this case, I will do the proximal stenting first. It's because the culprit is the proximal AD. So I always stent it first, and then we do the kissing everything later. So just the high pressure, the proximal part. Yeah, we also use the stent boost. This is the stent boost. So after that, because we had to do the high pressure ballooning on the culprit, so we have to check if there's any no refill. Now everything looks good, but it is not always. Almost always looks good, but actually not good. So always have to double check with the IVUS. So now we use IVUS to carefully check the distal landing was very good. Again, our first one was auto pullback, and so that we can measure all the length and have a record quickly. And then the second one is to manual pullback, move it slowly, and then see the distal landing and no dissection. Everything was good, good under expansion. The IVUS so that the stent was well expanded, is circular. And then the possible seems we can do more high pressure ballooning because here some malposition problem still under expansion. So before we do any rewiring on the side branch, we have to use a bigger NC balloon to do the high pressure ballooning. According to the IVUS, so After that, then we are confident to do the rewiring so that our wire will not go under stent stroke. I think different IVUS machine will have a different usage method. For us, if we use this IVUS, we will use this method. And always remember to see the hemodynamic at the same time while you do the AMI case. You can see that despite we use the IVUS, do the P-IVUS, the blood pressure hemodynamic is all okay. Most of the time, even acute case, you can use high pressure ballooning according to the IVUS unless in a very, very heavy thrombus low, then you may use small balloon. Just make sure the stent was well opposed, and then you may go. For non-STEMI, there's less concern or no refill, so we always just follow the IVUS size and then do the high pressure ballooning. And we use anchor balloon and then small balloon to open up the side branch, stent stroke, and then kissing. For this big diagonal, usually I will do long overlap kissing because the ostium most of the time is long oval shape. So for long overlap kissing is better to open up the ostium or the side branch. But the side effect is that if you do this long overlap, there will be longitudinal deformation over the stent stroke at the proximal LAD. So after that, always check the fold, and then we have to do the IVUS to see what happened. And finally, we do the pop. So let's see the final IVUS. You see the time is not long, it's real time, 1 hour, but we had too many IVUS one and carefully check. Now you can check the bifurcation actually is very good. Most of the pace, because we have calculated all the length, everything before we put the stent. So you can see that this single layer of stent structure in most part, and there we can use IVUS to measure and then minimize the stent overlap. You can see most of the time, all the part were covered with the stent, but the overlap area of the stent was very low. And then we see from the IVUS, they here still have some expansion problems, so we further high pressure ballooning it, and then that was the final result. Okay. So despite a 2-cent bifurcation with multiple IVUS one, we can still achieve it in a very short time. So don't hesitate to use it, and that is one of the way to use IVUS. I'm sure different operator will have different way to use. I just show it in live how we use it in non-STEMI case with bifurcation. And thank you.
Thank you, Ho LAM. I think I just have one comment. The case, of course, beautifully demonstrated. I think for the sake of the audience, whenever you are using imaging in the AMI setting, right, always try to get a good flow to your vessels and give a bunch of enough nitro to dilate the vessel before you use the imaging, because imaging will tell you the truth. But if the vessel is under dilated, it's not fully dilated, it will tell you the wrong number. So this is the most important key message I want to deliver. Otherwise, the big case was beautifully illustrated. Chris, quick questions?
Yeah, thanks, Lam. As always, a great case that you presented, and there are a couple of teaching points. And I think the selection of the patient was very, very good, because first of all, you got these diffuse disease, as Vince mentioned. Second, when you saw the first angulation, it was very busy. There were a lot of side branches crossing the artery, and you couldn't really clearly see where the artery runs. And third, you managed to put your LID stent ostial, which is always a crucial point. And it helps if you do IVUS or OCT to really depict where's the plaque load, where's the ostium of the main vessel, and how to optimize it. And you're often misled by just the angiographic images by itself. Just a quick thing. I saw you anchoring a distal balloon in the LRD to get the balloon crossing in the diagonal. And every time I experience some problem with crossing a balloon, I always go back and think that maybe the rewiring wasn't that good, or the pod wasn't that good, that I didn't really open up the struts. So did you think about doing extra IVUS run to see what the problem is, or just went through it by force?
Yeah, thank you, Dr. Jensen. Yeah, I also advocate that don't try to use force to push the balloon in. Only I actually adjust the force. It's not very vigorous force. Just by method, gently push in. You can see that my guiding is actually not that supportive, or not in a very aggressive position. I absolutely agree that if you feel very hard to push the balloon in, you should always consider rewiring as the first line before you use force, because all the complication happen before is using extra force. Then you more force, more risk of complication and more deformation on the stent strap. But this case, I don't use much force, although I use anchor, but I cause it.
Thanks.
Okay. Two short comments for Jamie, because we are lagging behind the schedule.
Dr. Ho LAM, excellent case.
Comment.
Yeah, excellent case, especially the use of IVUS in pre-procedural evaluation, identifying especially the distal reference and the landing zone, especially in this setting of diffuse disease and complex bifurcations, and deciding on a bifurcation strategy. I just have one comment. It appears to be a single crush strategy. Is that your default technique for bifurcations in the acute setting?
Yeah, it's always controversial. We used a lot of DK crush many years ago, but after 2015, I guess we changed to this nano crush, and we modified it. We had tried it in model and tested in many times. Firstly, after many years, the outcome is very good. Second, our theory is to make sure single layer of stent strap. You can see from the case from IVUS, from stent boost, is we can do 2 stent bifurcation in single layer of stent strap with this method, provided that your sideband stent is putting in a very correct position. You can make it, although it is unbelievable, but you can try in the model. We try it many times and completely reproducible, and even our second-year fellow can also do that. Yes.
And also, I think the use of IVUS is very appropriate. I think I just want to highlight like findings from the IVUS XPL randomized trial. The use of IVUS for such diffuse lesions, for such long stents in the IVUS XPL trial, at mean implanted stent was at least 28 millimeters. So the use of IVUS actually showed that there is actually better outcomes in terms of lower target revascularization in the IVUS guided arm compared to angiographic arm. Thank you.
Okay, I think for the interest of time, sorry, Vincent, we may need to go ahead for the next presentation first, right? So, Chris, maybe you introduce the next speakers.
Sure. So the next very important topic is the value of imaging in stent thrombosis. It's always the things that we are wondering and what is going on there. And we are happy that Dr. Chee-Yang CHIN gives his presentation on this topic and gives some insights on this 5 cents for it.
All right. Thanks, Christoph. Okay, so I think, as Alan mentioned, we're a bit behind time, so I'll try and be a little bit quicker. So my topic is the role of imaging for stent thrombosis. So I'm just going to go through a few cases showing what, some interesting pictures and certain instances where imaging really, I thought, made a bit of a difference. So first case is actually one of my favorite ever cases in terms of imaging. This is a 45-year-old man. In 2012, he had a Cypher stent So it's the first generation scrollum saluting stent implanted from the proximal to mid LAD. He also at the time had an LV clot on warfarin, but he was, at the time, a very young guy, and he was non-compliant to medications. 4 years after that, he came back for an anterolateral STEMI, as you can see on the ECG. And we performed, obviously brought him to the cath lab. So on the left is the final result from 2012. So stents from the proximal to mid LAD, and on the right was the emergency angiogram with for the anterolateral STEMI. Okay, so you can see quite clearly there's an occlusion with TIMI1 flow right at the distal edge of the previously stented segments. So after thrombus aspiration, we performed OCT. So this is the OCT pullback. So distal to the stent, the vessel looked pretty okay, yeah, relatively healthy. And here we start to see some thrombus, obviously, yeah. So this is thrombus protruding into the lumen and obstructing the lumen. So a lot of thrombus. Here we start to see the stent. So the thrombus protruded, or rather extended beyond the distal stent edge. Now we start to see some stents, which were implanted 4 years ago. And William kind of mentioned this earlier as well. Sorry. So William kind of mentioned this mechanism earlier as well. We can see these evaginations in the vessel. So this is a sign of positive remodeling. So it's not a sign of the stent collapsing in, but rather the vessel has grown outwards, such that at certain points, you can see that the stent is almost not even in contact with the intima anymore. So these are like hanging stent struts inside the lumen. So this predisposes, obviously, to thrombus formation. And this is something that was quite commonly seen with the first generation stents, such as the Cypher and the Texas stents. So you can see these very funny looking evaginations, almost flower-like, if you like, in the vessel. Okay. So a summary of what we found. So in fact, even on the angiogram, if you were very sharp with your eyes, you could see these little outpoachings. These are this is a peristrut contrast staining. Here's the occlusion. And then on the OCT, we see these evaginations of the vessel away from the stent struts, leading to some malopposed and almost exposed stent struts, which I think in this case was almost certainly the nidus or the source for the clotting. And this was a 3D reconstruction of the OCT, and you can see this is really very eccentric and very funny looking kind of a vessel. Normally it should be quite smooth. Okay, so I thought this case was very telling in terms of the mechanism, and also the images are really quite stark. All right, so anyway, for this case, we performed some POBA to expand the stent a little bit more. We had to add a second stent, a further stent, because there was thrombus beyond the distal stent edge, which we couldn't clear away. This was the final result. Okay, second case is a bit more recent. I just did this case 1 or 2 months ago. So this was an 87-year-old woman. In 2003, 2007, she had episodes of NSTEMI with stents implanted into her LAD and circumflex. And in 2022, in August, she presented to a different hospital with inferior STEMI and complete heart block. She was really quite sick then, and cardiogenic shock. And they performed emergency angiogram, and that showed an occluded ostial RCA. So they managed to reperfuse the RCA with 2 stents, designs 3x23 and 3x48 from the ostium to the mid RCA. There was also a lesion in the circumflex, a tight lesion in the circumflex, and she was sent to our hospital for the stage procedure to the circumflex. So this was that procedure with the cardiogenic shock. You can see she had to have a pacing wire implanted. She's got an IABP. This is the left system. You can see here that there's a very tight lesion here in the circumflex, LAD, some ISR, but otherwise TIMI3 flow. And this was the culprit, RCA. With some difficulty, they managed to wire it with a Fielder XT. This is what it looked like after balloon dilatation. And after implanting a couple of stents in the proximal as well as in the mid, this was the final result, which was quite reasonable, I thought. I think compared to what they started with, I thought it was a pretty reasonable result. No imaging was performed during this procedure as far as I could tell. And so we brought her back for the elective stage PCI to the circumflex. She was asymptomatic, 87-year-old woman. So fairly routinely, I would recheck the recently treated vessel, and this is what we saw, or this is what I saw. In the very proximal part of the stent, clearly there's a filling defect, and I mean, what else could it be apart from thrombus? So obviously I performed imaging. So this is the IVUS pullback from the proximal part of the RCA. You can see the previous stent. Expansion is pretty good. Around about this part, we start to see some structures protruding into the lumen. Here at 12 o'clock position, that's thrombus, irregular surface protruding through the stent struts into the lumen. Okay, the stent struts extend out a little bit out into the aorta as well. Okay, so there was thrombus inside, as we confirmed on IVUS. So I did some measurements. Stent area where the thrombus was not too bad, I thought, 8.45 millimeter square at that point. So I don't know, I probably can't blame them for under expanding the stent, but 8.5 was the measurement. Nonetheless, I performed a post dilatation with a bigger balloon, 4 millimeter NC. This was the final result that I got. And the final IVUS pullback, couldn't really see very much thrombus anymore. So the thrombus was cleared by the balloon dilatation. And the final area was about 9.4, slightly better than the 8.4 that we had before PCI at the start of this procedure. So 5 weeks after that, which was just 2 days ago, I brought her back again for the circumflex. So obviously we checked the right again. And you can see that there looks like there's a buildup again, right, of thrombus. It looks a little bit irregular there at the proximal part of the stent. Not too bad at this moment. Not sure what other people would do. At this point, I elected to leave the RCA, and I went ahead to fix the circumflex. I just ballooned and DB'd the circumflex. Result was pretty okay. I didn't want to put any more stents, but clearly we see this here. Yeah, we can have a discussion maybe afterwards about what other people would do. But for me, I left this at this point. Third case, 73-year-old man. Previous PCI with a bare metal stent to the RCA. That was 2008. In 2018, he came back with in-stent restenosis in the RCA. At that point, he had 2 further DES inserted, a Zions prime 3.5 by 38 and another one 3.5 by 23, proximal to distal RCA. And 6 years later, 2018, he comes back with an NSTEMI. Okay, so this is the final angio from his previous procedure in 2012. So stents from the very proximal RCA all the way to the mid-distal part of the vessel. Again, visually, not too bad. Angiographically, in terms of the expansion, certainly can't fault them for any gross under-expansion. And this was at the NSTEMI presentation 6 years later. So stent is, in the mid to distal part, still patent, but in the proximal part, we can see some filling defects, which I think you can appreciate. Even through the internet. So some thrombus, non-occlusive at this point, but certainly enough to cause a non-ST elevation MI. So perform OCT. So this pullback's a little bit fast. So perform OCT interrogation. So we can see this is from the mid part of the stent. So we can see previous stent struts here. There's obviously new intimal. There's already a new intima because it's I think 6 years old, right? The stent. At this point, we see within the intima that there's some lower attenuation kind of plaque here in the 1 to 3 o'clock. Here again at 6 to 9 o'clock. So it looks quite suggestive of lipid. And if it was lipid, then this would be a neoatherosclerosis kind of pathology instead. So here we start to see the thrombus, again, this irregular surfaced structure protruding into the lumen. But what's interesting is that at the area where I saw where we see the thrombus, there isn't a lot of plaque. There isn't like evidence of plaque rupture, or it doesn't look like the neoatherosclerosis may have contributed to it. But instead, we see some areas where there are exposed stent struts. Yeah, again, proximally, maybe if you can convince yourself, maybe there's a little bit of these little invaginations as well in the vessel. So again, in terms of the OCT summary, here in the mid part of the RCA, there are some low attenuation plaque, low intensity plaque with attenuation. So this is suggestive of a new atherosclerosis, thrombus. We can see here some areas of malapose stent struts, maybe some vagination suggestive of positive remodeling as well. So again, just POBA for this case. I don't recall doing a drug-eluting balloon for this case because I didn't think that was the mechanism. So it was just a POBA, and this was the final angio result. The final OC shows that the thrombus has more or less been pushed away. Okay, and this will be the final case that I show. This case, again, I did just 2 days ago. This was a 43-year-old man with a background of antithrombin 3 deficiency. So he has this tendency for clotting, supposed to be on lifelong warfarin, but he's non-compliant to treatment. He's HIV positive and with some CKD as well. So quite a bit of a history for him. He's got a left dominant system. In 2010, he came in with an interior STEMI. At that time, he had a PCI to LAD. Then 6 years later, there was ISR. More stents were put in the LAD from the ostium, to the proximal LAD. And then in 2021, last year, he came in with an inferior STEMI. He's got a left dominant system. So the culprit at that time was a large OM2. This was done at a different institution, and all they had to do was a POBA. And now he comes in with an inferior STEMI. This was his ECG. The STEMI, the ST elevation is quite subtle, but you can see complete heart block in this patient. So we brought him to the lab. His right is non-dominant. His LAD, in terms of the proximal to mid part, looks pretty okay as well. But in the caudal views, if you look at the ostium of the circumflex, it looks hazy. It looks like there's something there. There's still TIMI3 flow, but certainly there's something going on in the ostium of the circumflex. So I felt that must have been the culprit. So this was so I wired both LAD and circumflex. This is the IVUS pullback from the LAD. So previous stents in the LAD, you can see the circumflex coming in. This is the left main. Okay, and I think you'll notice that the proximal stent edge, the proximal edge of the LAD stent here is in the distal left main, or maybe near the polygon of confluence, but certainly it's gone across the circumflex ostium. It's malapose at this point. Stent was a 3 millimeter stent. The vessel or the lumen at this point was about 4.4, so there's some malapposition. And then the IVUS pullback from the circumflex. So this is the proximal part of the circumflex. Some plaque here becomes a bit dark. There's thrombus here at the 12 o'clock position. Thrombus, I don't know if you're convinced, but I thought, I'll show you the next pullback, which is this is a manual pullback. I'm not sure if you're convinced, but I thought it was more attached to the surface of the stent, the protruding stent strut. So here is the circumflex. I think here's the LAD. We see some stent struts, and we see the thrombus almost adherent to the stent struts. Yeah. So I thought the thrombus was mainly from the stent, and then obviously with some extension into the circumflex. My wire in the circumflex was under the stent struts, as shown on IVUS. The wire in the LED was okay. So at this point, there was a bit of a conundrum what to do about this case. The LED stent was a little bit protruding into the left main, but not really enough for me to do any pot or anything. I tried to rewire the circumflex through the LED, through the left main LED, and into the circumflex through the left main stent and into the circumflex, but I was unsuccessful. So at this point, not sure what to do. Should I just crush it with another left main to circumflex stent, try and be ambitious and do some kind of V-stenting, but then that would leave me with a big neocarina, or maybe just try and dilate this part first and then try and rewire the circumflex in some kind of a reverse culotte kind of technique. I went with the first option. I tried to crush it from left main to LED, left main to circumflex. So I took a 3.0 semi-compliant balloon. It went up very easily because it's all soft plaque. And then after balloon dilatation, this was the angiogram, and it looked really good. Right, it looked really good. So I then had a change of heart, and I wasn't sure I really wanted to proceed to do any further stenting at this point. And so I went ahead with a 4 NC balloon in the left main LAD to try to pose the left main stent a little bit more. The NC balloon kept slipping back, so I had to use a score flex, which gave me a little bit more friction and held the balloon in place a little bit better. And then the final IVUS on the left is the IVUS pullback from the circumflex. So again, the proximal part of the circumflex, you see some plaque, but I don't see any plaque rupture. So I don't think that was the mechanism. I think it was really just thrombus from the protruding stent struts that then extended into the circumflex. And this is the pullback from the LAD. There is still a little bit of malapposition, only slightly better. I already used because it was only very short extension into the left main. I was a bit hesitant to use a bigger balloon to further expand it. This was the final image anyway after ballooning. Okay, so those are the 4 cases that I have to share, and I'll stop here. Thanks.
Thank you, Chee-Yang. This were very nice cases of stent thrombosis, and thanks for all the images and insights there. In the interest of time, just a quick discussions, maybe a comment from Dr. Long on this topic. We are a little bit behind, but it's very interesting.
Just a quick comment. Thank you, Dr. Chin, for your excellent talk. So concerning about the second case, I also have some personal experience on a few cases of very early ISR in the osteo-RC position. And first few cases I observed is some protruding calcium nodule and in end-stage renal failure that tend to have very early aggressive ISR. The other is very aortic osteo lesion is tend to be very fibrotic. So sometimes I put in a stent. Even the stent balloon is, or the post-stent high pressure balloon is well expanded. The stent tend to recall, maybe due to the lack of radial strength of the stent, or sometimes I need to put in a second stent. So for some case, if I don't put in a second stent, they come back like in a few months' time for in-stent restenosis. So what I did now is I try using cutting balloon, not until I see some good dissection in the ostium fibrous plaque before I put in the stent. Otherwise, I observe quite a few cases that has actually recall. It's quite significant recall in the osteo position. Although the MLA is good, but the vessel is, if the vessel is big and there's a recall with elliptical or eccentric expansion, they tend to come back. So this is my observation in this kind of cases.
Yeah, actually, I have another case which I didn't prepare because that case was too long. Also, I think the underlying problem was the calcified nodule. Similar to this one, I did the RCA, PCI, and then 4 weeks later brought him back for the LAD. And then I saw, oh my goodness, there's a thrombus in the RCA. And I'm not exaggerating, but I did his RCA 3 times in the space of 3 months. Each time it was because there was a bit of thrombus. And on imaging, sometimes it's hard to tell whether it's really some calcium protruding or not, but I thought there was some evidence of calcium protruding. So like what you said, it may well have been a calcified nodule underneath that kept poking through the stent struts.
Yeah, I guess at the end of the day, you still highlight the importance of intravascular imaging, particularly you are not using a very in-depth procedure. So when the patient come back, I think it's always mandatory to investigate what is the cause of the stent failure. And particularly, you can try to differentiate whether it's the underlying calcium or the so-called fibrotic plaque that probably lack of radial strength, etc. Try to tailor-make the special individualized treatment for each of these kinds of stent failures. Okay, so I think really for the interest of time, we still have one more presentation to go. So thank you, Chee-Yang, again for a very enlightening talk. So the last speakers of today, again, you try to show some recorded live case by using OCT in the STEMI. So it's by Dr. Raymond CHEUNG. Raymond from, I think it's from Tuen Mun Hospital again. So Raymond, are you here? Yes, Raymond?
Yes, I'm ready.
Yes, go ahead. Yes, go ahead.
Sorry, some technical problem.
To share your screen?
Yeah, I'm trying to share my screen.
So in the meantime, let me ask Chee-Yang another question. You showed these nice images of this lipid plaque inside of the stent in the RCA. By any chance, did you do imaging after POBA? Did you look at how it looked like after balloon dilatation? Did it change? Was it gone? How did it look like?
Yeah, good question. We did do a final IVUS, final OCT for that case, and I did balloon that area just because I was there. I'll take a look at it again now. But from what I remember, it seemed to be dispersed. It seemed to be gone. That lipidic plaque inside.
Okay, it was very nasty looking with this thin cap and lipid core. If you think about vulnerable plaques, then this could be a really one. Okay, I think Ray is ready to give his talk, and then please, Ray.
Okay, so thank you for your invitation. Can you hear me? So hello everyone, this is Raymond from Tuen Mun Hospital from Hong Kong. I'm glad to present in TCIP 2022. The case I'm going to share about is my first OCT guided PCI for STEMI as a junior. So this is our patient, Mr. Chen, who is a 68-year-old man. He is a chronic smoker with a history of 40 years. He has a medical background of hypertension, hyperlipidemia, and also diabetes. He presented to us with acute onset of severe chest pain at 12 o'clock midnight while watching TV. ECG on admission showed sinus rhythm with ST elevation from V2 to V5, suggestive of anterior STEMI. Vitals are stable on admission, and he was not in heart failure. He was treated with thrombolytics during non-office hour, sent to CCU, and is prepared for pharmacoinvasive PCR the next day. So we sent our patient to cath lab the next day morning and performed diagnostic coronary angiogram. So we use a right radial access with JL4 and JR4. The most striking feature we can see is there is critical lesion at proximal to mid LAD with TIMI free flow. There is also some minor disease at the distal left circumflex artery. Live case was recorded in this case with simultaneous pressure tracing, angiogram, and also the cath lab. So the RCA, there's some minor disease and it is dominant. The culprit vessel is LAD, and we are going to do PCR to the LAD. So OCT was our choice of intravascular imaging in this case. We do OCT before and after the PCI. The pre-OCT, the pre-PCR OCT runs help us to determine the strategy of our PCI. So we are now setting up our OCT. The OCT imaging catheter, Optus imaging catheter is Dragonfly OpStar imaging catheter was being connected to the Optus operating system. So we are connecting the imaging catheter to the system, and then we deliver our Dragonfly OpStar catheter to our LAD. The catheter was being purged, followed by calibration. So it is now doing the calibration part. So we press and hold on cine and inject the contrast within the 15 seconds time frame. Rapid pullback was being initiated. So the OCT is analyzing and processing the image. So the OCT is analyzing the images of our LAD from the proximal part to the distal part. We can see there is diffuse disease here. So we are trying to find out the landing zones of our stent. This window is our distal landing. This window is our proximal landing. And for this window, it shows where the image this cursor lies on. So this is the concluded part of our OCT. So we found out the distal landing is here. The diameter of our stent would be 2.5, rounding down from the EL of 2.59. The proximal part of diameter of the proximal stent would be 3.5, rounding up from the lumen 3.18. So the stent length would be 64 millimeter. So at least 2 stents have to be used. So after determining our stent size and diameter, we are going to deliver our stent. So we first deliver the mid-LAD stent. Science 2.538 was delivered at mid-LAD at up to 12 atmosphere. We wire both LAD and also the left circumflex artery for protection in this case. So our second stent, science 3.528 was delivered at proximal LAD at 12 atmosphere, overlapping with our mid-LAD stent. So after delivering our stent, we are going to do post-stent balloon dilatation. So we use NC-track 2.5 and also NC-track 3.5 balloons to dilate our stents from the distal part to the proximal part. So after stent delivery and also balloon dilatation, we perform angiography. So it shows apparent good angiographic results. The flow is good. The stents seem well expanded and there's no acute complication. So we still repeat OCT after our PCI. So again, the OCT was set up. This is our second run of OCT. The imaging catheter was delivered to the LAD, and the imaging catheter was being purged, followed by calibration. So it is during the calibration part. So we press and hold on STEMI and inject the contrast within the 15 seconds of time frame. Rapid pullback was being initiated, and we can see the stent strut here already. So the OCT is analyzing our stent from the proximal part to the distal part. It can use AI to automatically identify the stent in the vessel. The stent seems to have well expansion, but we can see there are some orange parts here. So this is the orange part here, which highlights some of the areas of under expansion by using artificial intelligence. The areas of under expansion is only around 70-something%. So this is the concluded OCT image, which shows despite balloon dilatation with high pressure, there is still some area of under expansion as highlighted by the orange part, which is only 74%. So with the information of the OCT, we repeat balloon dilatation again with a 3.0 balloon to dilate the underexpanded part at up to 16 atmosphere. So from the distal part to the proximal part. After that, we will repeat OCT again to look for our expansion results. So this is our third run of OCT. The imaging catheter was delivered to the LAD again and is being purged for blood clearance, followed by calibration. So we press and hold on STEMI and inject contrast within the 15 seconds. So rapid pullback was being initiated. So the OCT is analyzing our images. So it shows our stent from proximal to the distal part. So this is our stent. So in this run, we can no longer see the orange areas highlighted in our second run of OCT. So it shows that the stent expansion is acceptable after our second balloon dilatation. So we compare both pullbacks. This is our second OCT run, and this is the third OCT run, which shows the stent expansion is better with the information supplied with our previous OCT run. So finally, we performed our final shot with this. It shows really good angiographic results, nice flow, nice stent expansion, and there is no acute complication noted. So the patient was stable and he was discharged 3 days later with normal chest pain. So OCT was used as a choice of intravascular imaging in this case. It makes good use of infrared light to provide high definition 3D and also cross-sectional images of the artery for precise assessment of lesion characteristics and plaque morphology of the lesion. Compared with IVUS, it is better in terms of image clarity, faster pullback, assessment of calcium, and is a function of AI. However, it also has some disadvantages, mainly related to the need of blood clearance, thus making it less versatile than IVUS for certain lesion subsets. So intravascular imaging has been proven to improve the clinical outcomes and should be more used in clinical practice. So we usually do OCT before and after the PCI. So it can help us to change our treatment decision when compared with doing coronary angiography alone, and can help us to reduce major adverse cardiac events. For the pre-PCI OCT, we are interested to look for the MLD, which stands for morphology, length, and diameter. Because different lesion morphologies may require different treatment strategy. For fibrous lesion or fibrocalcific lesion, maybe balloon dilatation would be enough for lesion preparation. However, for those heavily calcified lesion, for example, those with more than 180 degree, with more than 0.5 millimeter thickness, more advanced technologies such as shockwave and rotablation may have to be used. OCT can make good use of its software to automatically identify the EEL and also lumen diameter. It can help us to choose areas with good landing and to avoid landing on high-risk areas, for example, areas with lipid pools or thin cap fibrosarcoma, as mentioned before. Also, it can help us to determine the stent diameter. If we measure from the EEL, the stent diameter will be rounded down. If we measured from the luminal diameter, the stent diameter will be rounded up. For the post-PCI OCT run, it helps us to optimize our stent deployment. We are interested to look for MAX, which stands for medial dissection, apposition, and expansion. So it can help us to find out the angle and the length of medial dissection. It can also use software to help us to identify the length and also distance of malapposition and expansion. For example, for underexpansion, less than and more than 80% is acceptable. So in our case, our OCT make good use of software called Ultron, which is a newly developed software which can use AI to facilitate our PCI guidance. It can help us to find out morphology, sizing, deployment, and review. For the morphology, it can automatically detect degree and thickness of calcification, so which can help us to choose our treatment strategy. For the sizing, it can use AI to detect EL and lumen to help us to identify landing zones. So in some OCT, there's also a feature of co-registration, which could allow side-by-side viewing of live and co-registered angio to help us to guide precise stent deployment. Finally, it can help us to review the stent expansion and apposition results with instantaneous display of the expansion and apposition, just like our case. So in this case, I was allowed to do the PCI from the beginning to the end, from puncture wiring, coronary angiogram wiring, and OCT, and also doing balloon dilatation and stenting. So live procedure video was recorded with simultaneous fluoroscopic image and pressure tracing. And this case shows OCT can use AI to locate areas of underexpansion and improve our expansion result and change our treatment decision. So it comes to the end of my presentation, and thank you for your time and kind attention.
Okay. Thank you very much. I think Raymond beautifully illustrate again the new software. That's just for the side track. Many of the not all of us around the world are able to use this software. We had just had a hot discussion in the side track in the chat room. Then many of the panelists here, some of us have the chance to use it. And it's part of some of the South Asia, of course, the US, some of the European countries. But this is still penetrating. But I think at the end of the day, you beautifully illustrate how streamline is the new functions, the Ultron. I think particularly OCT, the platform is trying to incorporate the so-called MLD Max into the algorithm, into the system. So it just automatically highlight the, for example, the length, the diameters when you're choosing the reference segments. And then also they try to assess the expansion and position, etc., etc. They also have, I think they have the features that we are still figuring out how helpful is the real-time co-registration to guide you to play your stent. So we are still focusing on this function as being told by the product specialist, and this is also one of the new functions. And of course, I just want to hear any comments from the panelists. But using or any panelists have a chance already using the Ultron software, they will share their experience, etc. Does Singapore have the Chee-Yang? Is it available in Singapore yet?
Ultron, no, we are still using.
Should be available soon, I guess.
I've been asking, but still waiting. Yeah.
Means it in Europe here, in Europe. So how is the penetrance? Is it available in most of the European country? Or
yes. I think it's available in all the European countries. Actually, in my center, we started the OCT program with Ultron. I think we've been the first center in Italy that started the OCT program with Ultron. I have to say, I had previous experience with OCT, with previous software. I have to say that Ultron definitely makes things quicker. The automatic detection of calcium is very helpful. The MLD Max protocol is easy to use, and I definitely have some good experience, except when you assess all the stents. The assessment of so basically the software is not able to tell you if the stent is fresh or old. So when it comes to decide what to do, so postulate, not postulate, to understand what is the cause of stent failure, I think that there's more work to do. One other issue that was in the 1.0 version was the lack of MLA and MSA, so you could not tell the exact value of MLA and MSA. So it was a problem when you were doing left main cases. but now they fixed that with a new version. And I think there's a lot of work in progress, but the feedback from my point of view are very good so far.
Yes. Chris?
Yeah, just a quick question from my side to all the alternate users. We could thanks Raymond for this great demonstration of all the features that this new system can bring us and then improve the progress in the cath lab. But so my question tends to the setup. So what do you think? How much time does it take to set it up, to run it? Like how many operators? I saw there were in between there were 3 operators, but this is probably just because you're in the training of an interventional cardiologist. So what do I have to expect? What time that I need to have extra, and how many operators in a normal setting?
So I think that it takes a longer time for us to set up the OCT in this case, because we don't have much experience in this time. But during this case, we have set up the OCT for 3 times already. So in our second or third run of the OCT, it gets us much quicker to purge the catheter and also to deliver the imaging catheter to the target vessel. So I think that we finished our case not too long. Maybe it takes around 5 to 10 minutes for us to set up the OCT for our first run, and for our second and third run of OCT, it may take only around less than 5 minutes for us to prepare the imaging catheter.
Yeah, I think basically the new system, I think this just follow the same tips and tricks for using the OCT as in the first version. So basically, I think the live case, the recorded live case, illustrated several important points. You need to get a good coaxial guiding first, and I can show they are just using handheld injection, manual injection, which is not by any power injectors. So I think you need to have a good hand, coaxial alignment of the guidings, and then if you have adequate contrast displacement or of the blood displacement, you can get a good image. I think this all was shown in the video. So it's because of the every step-by-step build up of the system. So much, I think for the learning curve, probably if you are never using the OCT before, the right recommendation is probably 5 to 10 cases you get quite familiar with. Of course, at the beginning, try to get your product specialist to handle the measurement for yourself. Of course, when you have already become an intermediate or advanced users, they can have you have the joystick and the control panel installed next to your handrail of the table, and then you can operators can manage it by yourself, which is I'm always controlled by myself, because it's more quick. I'm not can't wait longer enough for the product specialist to measure anything. But of course, at the beginning, I strongly recommend to ask your product specialist to do the case with you, and then they will guide you, and then they will at least try to illustrate most of the function for you as well. When you get familiar, and then you get extremely user friendly. Of course, this a few learning curve for the beginning case. I think is the lamppost that beautifully demonstrate what is the essential of the today's the importance points is try to introduce the imaging to the junior. I think once they know the usefulness of intra imaging in using tackling complex lesions, they will start using them in the future. So I think this is what we are lacking behind. But in old days, when our old mentors are not using imaging a lot, but hopefully, and nowadays we are organizing a lot of these important conferences talking about spending 2 hours and talking about intracoronary imaging. I think to teach our next generation of interventional cardiology is always important by using these kinds of techniques. Otherwise, you just jeopardize the care of the patients. So, are there any final comments from the floor before we conclude the session? Because we are a bit late, but it's not too late.
I must just one short comment. I must say that I demonstrate the use of OCT for once for women, and then the third one was completely do by women. So it actually is not that difficult. At least you can see young fellow can also do it very well for the second and third one after just seeing one. Yeah.
I think they see the good side of the technique, so they will learn from the rest of their life. So in case if there's no other further comments, thank you very much for all the audience and panelists, the speakers tonight to give the very excellent discussion all throughout the last 2 hours. We all always enjoy very much. And I'm pretty sure we'll come up with another great sections in the short-coming futures with covering different aspects of the intracoronary imaging and physiology. So thank you very much again. Thanks for the co-organizer, etc., all the audience, all the participants, and hope you see you again soon. So good night.
Thank you.
Good evening.
Good evening. Thank you.
Bye.
Goodbye.
All right.
Bye-bye.
Bye, everyone.
Thank you very much.
See you all again. Bye-bye.
All right. Hope to see you again soon.